called Mats Brittberg, whom I knew before. But they were the first who started to take cells out of the body, cultivate them, and then put them back. And then there was a hole, and they had periosteum from, and they stitched it back. ACA. Autogenous chondrocyte implantation. So, and I was, as everybody else, was really very excited. And where I was, we had a randomized control study up running a couple of years later with microfracture, controlling microfracture. But then what happened was that the lab where we sent our cells to, that lab was sold to an American company called Genzyme, and they wanted $10,000 for every patient that we had, and we didn't have that kind of money. So that was the end of that study. But I managed. I did personally about 20 ACIs then in the mid-90s, and my experience was not a good one. It did not work well in my hands. It may be that I was a poor surgeon, possibly, but I didn't really want to think that was the cause. So, but I was disappointed, but the rest of the world was enthusiasts, and you know, the ICRS, the International Cartilage Repair Society, was created after that meeting, and I'm a member. It's a very good society, very active, and they keep developing this, and they now they are at generation 4 or 5 even on cell transplants, and we are still not globally in a position where cell transplantation has caught on to a point where everybody knows, like, you know, when the total hip prosthesis, it swept the world and everybody was doing hips and everybody was agreed that this is great stuff. That did not happen to ACI. So, and in fact, very significantly, I think that the ICRS changed their name just a couple of years ago into the International Society Cartilage Repair and Joint Preservation Society. And that's a thing. We want to stay out of total joints, total knee arthroplasty, because I mean, if you're a patient, 75 years old, that can't walk at all, you can't even go out and get the paper, then whatever we do to you is an improvement. And that's the case when I started doing total knees in the 80s. But we have come a long way from that. Now our patients want to do much more than that. They want to play golf or tennis or do many things. And many of the total knee can't do that because 20-25% of these patients are unhappy with their knees. So, about 15 years ago, I was, by a series of lucky coincidences, I was given the opportunity to start this project that ended up, again, it was a research project up in Stockholm. And I thought at the time that if cells don't work, why don't we put a metal button in the hole in the cartilage? Think of it as a dental filling. You know, that's what we do. My experience with total knees was that in Sweden we put in total knees without the patella button. Ah, thank you very much. Oops. Without a patella button. And we let the high layer articulate against the chrome cobalt that we are using in our implant, and that works well. In fact, the revision rate of the TKAs in Sweden is somewhat higher for the implants that are done with a patella button than without the patella button. Statistically significantly so. So I thought, why don't we do that? And we let the opposing cartilage on the tibia or on the patella articulate against the chrome cobalt button that we put in. And so here we are. Here is a hole in the cartilage. This is what you see in the knee and in the arthroscope. And this is what I saw way back then. And so this would be an osteochondral fracture. When you twist the knee, you flip loose a piece of cartilage. It sits very consistently on the apex of the medial femoral condyle. And so this is the torn cartilage. Now I suggest to you, and I see if you agree, that you can always also have these. Now, I mean, you can see, Dr. James, that you have normal cartilage up here, but here you see some kind of cobblestone cartilage. And I suggest that that's a kind of lesion that appears in the cartilage a good time after you've had a trauma that is less than to give you a fracture. But it's more, it sets in motion enzymatic processes in the matrix. Collagenase, metalloproteases degrade the matrix in a slow biological process that takes perhaps 10 or 15 years. And at age 30, 35, you're left with a hole in the cartilage, a new hole in the cartilage, slowly developing. If we don't do anything with that, that will develop into osteoarthritis. They call it the pothole effect, potholes in a road. You drive over it and it gets larger and larger. Here we know that cartilage kind of falls into the void. And so the lesion propagates. And let's say 40 years after the trauma or the traumatic period, because I mean, people play soccer, young people, they do all sorts of things, and they get multiple trauma, small trauma, but that develops into this process. So that's what we're dealing with, the hole in the cartilage. We want normal cartilage around it, and we want the opposing cartilage to be reasonably good. And we pay a lot of attention to that, and I will tell you about that. Another example of what we can do with our products is if you have an osteonecrosis, you have a bony defect. We have done a number of them, and they work very well. We just simply do the implant a bit thicker, because it is a patient-adapted, patient-specific implant. The curvature of the joint surface is patient-specific, and if need be, because there is like a bone underneath, we do it thicker. Another product of ours is the talus. After a sprain in the ankle joint, you sometimes develop an osteochondral lesion like that, and this is interesting, what you get with the trauma is a fissure. It's not really a lesion in the cartilage, it's just a crack in the cartilage. And then joint fluid is squeezed down into that cartilage. And then you develop huge cysts, and we see talus cysts now that the cysts are huge, and you wonder how does the bone hold up.
So this is Professor Sunday patient was something similar. There was only a fissure.
We did live surgery up in
Sikot,
Jaipur.
Jaipur. Sikot, yeah.
And it was a beautiful case, a 1 centimeter crack. That's all it was. And there was a huge cyst underneath. And that cyst is under pressure because there is a valve mechanism, or maybe a valve mechanism. So the patients, they have pain, they have ache, nightly ache, they can't sleep. So they are very tough. And that's a great indication for an Episealer. Now, we aim what we call for the gap patients. We aim for the patients, the age of the patient being above 35 years of age or something like that, because below 35 years of age you may want to do biology of some kind. You may want to do ACI, or BMAX is something that is popular here in India, I learned. I don't have any experience from BMAX. But the biologists themselves say that cells do worse after 30, 35, 40. There is something happening with these cells at some age, and that's when you can try our stuff instead. And then when the patients approach, let's say 65 years of age, you can do a total knee, or a total knee. Yeah. So that's a gap age, and we've been doing now. We are approaching 2,000 procedures with this device, primarily in the knee. Indications then, when you have younger patients that you have tried microfracture, you've tried ACA, or you've tried VMAX and they fail, well then you don't really know what to do with them. And then you can try even in young patients. And we have a small number of patients in their 20s, and they do just as well. The problem is that we don't yet know quite how long it lasts.